Hi, everybody. Welcome to today's session of Cafecito, entre. As we get started, feel free to share in the chat where you're from. Let us know where you're joining us from. Today, we will have a conversation with Dr. Roberto Lewis-Fernández on the Cultural Formulation Interview. This is our first session of Cafecito, entre. So we're excited to begin this new initiative where we will have enough time to speak to a professional who has developed multiple resources for Latino populations. So we're very happy about that. We have people joining us from Austin, Oakland, California, Houston, Hartford, New York, Maryland, Chicago, San Bernardino, Boston. Welcome, everybody. Next slide. So for today's session, we have simultaneous translation to Spanish. So if you want to use the simultaneous translation, you can go to the interpretation tab on your Zoom panel and click Spanish. You can also mute the English speaker's voice by clicking mute original audio. Para escuchar la presentación de hoy en español, vaya a la pestaña de interpretación en su panel de Zoom y haga clic en español. También puede silenciar la voz del presentador en inglés haciendo clic en el silenciar audio original. During today's session, I want to let you know that this session is being recorded and it will be made available publicly through our website and other media channels. All participants will be muted during the beginning of the session, but we will have about a half hour available for discussion. So you can raise your hand and we'll be able to unmute you so you can share your questions or comments. Please make sure that your computer speakers are turned on and up to hear today's presentation. If you have any technical issues, please send a message to the Hispanic Latino Behavioral Health Center of Excellence on the chat box. You can also use the Q&A if you have any questions. Simply type your question, hit send. We can address the questions to the presenter. Also, we will be sharing a copy of today's presentation in PDF format through the chat box. We will also make a copy available for download through our website. You can access that there. We will also share the link for the Cultural Formulation Interview for those of you who are interested in accessing that as well. Next slide. Once we complete the webinar, please complete the evaluation. This will help us continue to do the work that we're doing. It is important for us that you share your opinion and thoughts about the work that we're doing, the sessions, the topics, and any other feedback you might have for us. You will receive a certificate of attendance by email approximately a week from today. Please remember to check your junk folder just in case. For those of you who are joining us for the first time, we're the Hispanic Latino Behavioral Health Center of Excellence. Our mission is to advance and support the sustainability of behavioral health by promoting community-driven, culturally grounded, and person-centered prevention, treatment, multiple pathways of recovery and recovery support for Hispanic and Latino communities. We strive to accomplish this mission through the development and dissemination of culturally informed, evidence-based behavioral health information, providing training and technical assistance, and supporting the growth and expansion of the behavioral health workforce that serves Latino communities. Our learning objectives for today include sharing an overview of the Cultural Formulation Interview and its development, discussing the areas the interview explores, addressing possible benefits of using such an interview, discussing with the audience the pertinence with Latino populations. Now let's meet our speaker, Dr. Roberto Lewis-Fernández. Dr. Lewis-Fernández is director of the New York State Center of Excellence for Cultural Competence and the Hispanic Treatment Program at the New York State Psychiatric Institute and professor, Department of the Columbia at Columbia. He is a professor, as I mentioned, of clinical psychiatry at Columbia College of Physicians and Surgeons and director of the Center of Excellence. And research area. He's a leader in anxiety, mood, eating, and related disorders at the New York State Psychiatric Institute. But I will let Dr. Roberto Lewis-Fernández tell us a little bit about your professional trajectory.
Well, welcome. Thank you for inviting me. Welcome, everybody. I would like to leave a lot of time for discussion if possible, so I'll try to be brief in my comments. I'm originally from Puerto Rico. I went through high school in Puerto Rico, and then I went to study in the States, and then we became a psychiatrist and trained in cultural psychiatry in a postdoctoral fellowship. And then I returned to Puerto Rico for a few years and eventually accepted a job in New York, where I am now, both at Columbia and at the New York State Psychiatric Institute, which is a state institute that is sponsored by the Office of Mental Health, the Mental Health Authority of New York State, to perform research on disparities in the service of mental health services delivery about mental health in New York State, basically, and with repercussions nationally and internationally, if possible. But their main priority is, of course, the state. Then there I have worked, as we will discuss today, on the Cultural Formulation Interview, which I will define in a few minutes. We'll go through it. But it appeared in DSM-5 for the first time as this word always gives me away that I'm originally a Spanish speaker, the operationalization. I cannot never say it right. Operationalize I can say, but operationalization I can't say in one sentence. Anyway, how to operationalize the outline for cultural formulation, which appeared for the first time in DSM-4, and it's a narrative framework for how to perform a cultural evaluation in routine mental health care. And people had trouble coming up with questions for how to formulate those domains. How do you assess cultural identity, for example? So we came up with a bunch of questions in the Cultural Formulation Interview in DSM-5 about how to make it more user-friendly. And they're not perfect questions, but they did go through a field trial of over 300 people and 80 relatives or whatever, a lot of folks around the world. And we improved the questions as best we could. And these are attempts at formulating what I'm in a minute, say about it. I also worked on the DSM and other elements, other aspects. And I'm currently the co-chair, the vice chair of one of two vice chairs of the DSM steering committee that handles the essentially the updates to the DSM between major revisions. And the next major revision will be in a few years. But since the DSM-5 came out, we have been fielding any changes that people propose to be made to the DSM. That was the brief answer. Can you imagine the long answer? So I'll stop there.
Thank you. I appreciate it. And speaking about culture and the Cultural Formulation Interview, can you say a bit more about culture and how it's defined?
Sure. Can you advance the slide, please? Great. The next
The other one.
Yeah, the next one. Yeah. And so maybe you should, yes, that's right. So thank you. So the idea is important to get us all on the same page of what is culture, because the Cultural Formulation Interview is based on a certain interpretation of culture. People often, and it's important that we get that interpretation, we get on the same page about it, because otherwise the interview doesn't quite make sense. The idea for culture is not consonant in our understanding with the notion of national origin or ethnic background or race or ethnicity. It's culture is seen from anthropology as a process of making meaning about the world. Like, how do you make sense of the world? And the traditions that you learn in order to learn about the world, because we don't make this up ourselves entirely. We combine things that we learn over time and create new ideas from them, but they're usually based on what we know before. And also, how do we behave in the world? Social practice, as it says there. So meanings about the meaning of the world, how do you make sense, and also how do you behave in it? And it's always connected to our backgrounds, so we want to know about those, because we come from a certain age group or gender or sexual orientation or national origin or religion. We will have certain general ideas that we're exposed to in growing up. And it's always been the case that culture has never been, quote, pure. There's never been such a thing as pure cultures. Never. Not in the whole history of humanity. That was an idea of the late 18th, early 19th century of the Romantic movement, that there were essences to cultures that could be captured. And instead, there are particularly developing ideas and things that are common in particular areas, but they're all interconnected and mixed. And within each place, there are many, many ideas. The people in the next generation have different ideas. Women tend to have different experiences and so on. So it's important to not have it be static, and you must engage the person, because he can't assume that by looking at them, that they have certain ideas or practices. You have to engage them about it. And if you click one more time, the idea of the fish is explained by the fact that most of these things are unconscious. We are not. It's actually what we think of as being common sense. Doesn't everybody think like this? Are the areas that we are particularly interested in, because they are especially guiding your behavior and your ideas, interpretations, but we don't even question them. So we as a clinician need to understand the person, even what they don't know they know, in a certain way. That was the short answer.
So we're moving beyond this idea that culture is where you come from, your traditions and your language and your norms, and really it's a lot more about in a sense, we have many cultures,
right,
that we live in. Mm-hmm.
Right, and we change from moment to moment. So we're not. This is important to realize when we're doing this cultural formulation interview at one time. We may put forth certain ideas that are very important for us at the time, either because of something that has happened, or the person you're talking with, or the context in which you're at. But an hour later, we may have slightly different ideas by virtue of the different contexts in which we are. So we really want to know what's important to you now, and how are you thinking about it now, so we can help orient your healthcare. For example, you're not the same with your primary care doctor that you are with your priest, or your rabbi, or your coach, high school coach. You present different ideas, and that intersubjectivity is something that is important to engage in the interview.
Thank you. Next slide.
Right, so in the DSM, can you click again and again? There's 4 pieces, thank you. There you go. In the DSM-5, this is the TR versus text revision, came out more recently. We define what culture is for the purposes of the CFI, the Cultural Formulation Interview, following more or less what I told you a minute ago. There are different processes, values, orientations, knowledge, practices. They're connected to the person's background. Their family, friends, and other community members are super important. We call them social network, because their views are really important to you and how you frame your ideas. They help enculturate you, as we say, in your childhood. So it's really an important element that surrounds you, that we want to know their perspectives, because that way they would tell us more about what you think or do. And then the last one is that culture also encompasses the healthcare organizations and clinicians that are working with you. It's a reflexive process where you actually want to know more about the experiences they've had in the past, because that culture and your culture as well, and the culture of your organization, help shape the clinical encounter.
Thank you. And So how was the need for an instrument or an interview such as this one? How did that come about?
It's an interesting process because there have been the DSM, let's start there. The DSM has gone through major revisions over the years, and it came a point when the DSM became dissatisfied with its lack of attention to these elements, and also because a lot of people were protesting against it, leaving them out. So internally there was a movement of interest, and externally that was driven by external factors about how this was a very salient aspect of experience that was not being considered in these standard rules-driven kind of diagnosis. It also, for me, one thing that really made a difference, I speak as a participant, but I don't know exactly what they were thinking at each time, but I've been engaged in the DSM process since 1991. As I say, for my sins, I have been engaged in the DSM for that long. And the people at the beginning of this, when it was first appearing after 1980, when DSM went from a certain kind of manual to a different kind of manual, let's say, people thought they could, quote, carve nature at its joints and be able to internationally find the same disorders everywhere. And there were major epidemiological studies that really were predicated on following these criteria and thinking that they would find equivalent numbers everywhere. And they didn't find that. And I think that was a big shock to them. They found very different prevalence rates all over the place. True, rare things are rare and common things are common, but they're very big ranges. And so that stimulated them, I think, to look for culture. It's a very important part of how people engage with mental health services. It's also another reason why people participate or don't participate, choose certain kinds of treatment or don't choose certain kinds of treatment. So when these things became more and more obvious that we were leaving them out in the DSM, I use the we, but I wasn't really a part of it then we needed to include them better.
So I'm thinking that probably resulted in misdiagnosis at the time, and that was part of the reflection process. It still does. It still does.
So there's a tremendous amount of misdiagnosis, but at least there's been an attempt in the communicating through the manual, which is it is an imperfect way of communication through the manual, to say that these things are in need of paying attention to how they vary across populations. You know what? One secret, so to speak, of the DSM process is that the DSM folks are many of them, not all, but many, are very aware that it is it's overinterpreted as not being diverse. It's not being, how do I say it? The criteria are heuristics. They are attempts at approximating something that is not purely composed by those criteria. It's not that they think that major depression, if you don't have 5 out of 9 symptoms, you just don't have major depression. Most of them are aware that this list of 9 symptoms is a very useful list. It's been studied and it's not terrible as a list of symptoms, but it doesn't include everything that you possibly have if you're depressed. And so that, I call it subjunctive, but it's not a very good word. That way in which you take into account what if or as if, element of the list of criteria is an important thing to remember. It isn't written in stone that if people don't have exactly those symptoms, they don't have a disorder like the one in the same major depression or panic attacks. These are examples of symptoms. And we need to keep that in mind when we apply the diagnosis. It's an attempt at speaking the same code language and not using very different definitions. But the definitions are not written in stone. And I participated in writing these definitions. So I know the discussions that come up. They're attempts at being clear.
but in reliable, but in being clear, we leave out a lot of stuff. And it's obvious that as we do this work around the world, there are more and more differences that we find. For example, Latinos have a lot of physical symptoms, somatic symptoms, when they express certain disorders. Depression is a famous one, anxiety. But the list of somatic symptoms in depression is not very long, right? It's only so many of the 9 symptoms. There could be many more. And that doesn't mean that if you have those symptoms, you don't have depression. It just that you could substitute those symptoms, but you have a struggle between doing that too widely because you don't have it. Then you don't have a definition, you know.
And that has important implications for treatment, because
very important.
Even if someone doesn't have the 9 criteria, you're still going to treat it as depression, right? So
yes, that's
the experience.
That's exactly the point. There was a very good article back in 2017 by Ken Kendler, who was one of the best, I think, American psychiatrists, who was also very active in the steering committee, where Ken made the difference, drew the difference between an illustrative use of the diagnosis and a constitutive use of the diagnosis, of the diagnostic criteria. These are illustrations of symptoms. They're well studied. They work many parts of the world, but there are parts of the world that show differences that are not on the list. And that's the illustrative way, where you realize that these are examples, they don't constitute the diagnosis. A constitutive approach is where you say, if they don't have that, they don't have it. You know, we're not at that stage of psychiatric, mental health, psychological development. We just can hint at probably they have this disorder, and if we follow the guidelines, they meet these criteria. But it could be that they have some very slightly different or similar symptoms that aren't quite those on the list, but they still have the disorder, so to speak.
Yes. So we have an illustration of the CFI that we can share with the audience. We know that we mentioned the Cultural Formulation Interview, and it is a semi-structured interview. It's person-centered. So can you tell us a bit more about it in that sense, the components?
I'll try to be brief. The idea is this is what it looks like on the page. And it has 16 questions. The next slide in a minute, don't show it yet. The next slide shows the domains, the 16 domains of the CFI. It has the CFI that we're talking about is the one that we use to evaluate a patient. There's also a version to interview a family member. There's a version to ask more questions, extra modules. But the basic CFI has 16 questions, and it has these 2 rows where the one on the left there in italics tells you what the question means, what it's going for, and the one on the right is the actual question we came up after field trial to try and improve it. Next question, please. Next slide, please. This slide shows you the next one, please. Shows you the domains, and there are 4 parts, and they ask about what the person thinks is going on. What do they think is causing it? What's the context of their happening? What kind of support or problems, stressors are they having? And how does cultural identity make a difference to their expression or feelings or dealing with this problem? And then the third section asks what they've done in the past and done by themselves, look what kind of help they sought, of any kind of help. And then the last section there in green asks very specifically about what they want to do now and how the practitioner can help them achieve their goals, essentially get better. So those are the 4 domains of the CFI, and they have specific questions. And in 3 places, we ask about what the social network, as I defined before, thinks about the question. So we ask, what does your family or friends or others feel is the cause of your problem? And, like that. There's 3 places. One is how do they define it? What do they think is the cause? And the third one is what do they think should be done about it, as a way of complementing what the person themselves thinks.
Next slide. Thank you. So I'm sure there were a lot, but can you speak about some of the challenges in the development of the CFI?
Sure. No, it needed to be very brief. There's several challenges. It needed to be very brief because clinicians don't have all the time in the world. So, and because the manual really insisted, DSM really insisted it be very brief. So that limits the number of questions you can ask, and there are many more that could be asked, and these are just the basic questions that we think you could ask in an assessment. So there's that issue of brevity. There are more questions, as I said. There are supplementary modules in the website of the DSM that say, if you want to know more about this area, ask these. These are 10 more questions you can ask on each area. 30 questions for cultural identity, for example, something like that. The other thing is that it is unfortunately overly focused on diagnosis because it is a diagnostic manual. So the evaluation had to be oriented towards diagnosis rather than say, there is a question on how do you think you need to be helped now, but there are not many more questions on treatment or other elements of the clinical encounter. It needed to be relevant to making a diagnosis. So in that sense, there is, by virtue of being DSM, and this is one of the conditions for it to be there, we wanted it to be in DSM because it has a tremendous reach. Many people around the world have seen it because of being in the DSM, but that meant we had to focus on diagnosis, and perhaps diagnosis is one of the lesser aspects of treatment that is influenced by the CFI, much more about engagement, therapeutic relationship, decisions about treatment, inclusion of family, person-centered assessment, getting their perspective that doesn't always coalesce around diagnosis. There are many more aspects of the situation that would contribute to the person's, understanding the person other than the label, the diagnosis we give them. But it had that reality because of the way in which it was created.
Mm-hmm. So I think you already mentioned a few of these, but what would you say are some of the benefits of using the CFI?
It's very important to get a fuller picture of what the person is going through, not just I'm a psychiatrist, but we focus on labels and, criteria and so on. Many people focus on something else when they're helping people therapeutically. But it's very important to get their point of view, a person-centered perspective on what they think they're going through, what they've done about it, what do they expect, what do they fear. These are incredibly important narratives that you want to understand about the person. And the person then becomes an expert in their own experience, and you become somebody who is learning from them as a clinician. And that's very important. And of course, you have a role. Once you know these things from them, you have to give your opinion, help them find a way to get better. They're looking to you for help, not just for hearing what they have to say, though hearing is important too, but they also want to have you help them figure it out what to do. So that sense about the contextualizing their experience, hearing their perspective and their world in which they live. One element that's important are the resources, the so-called structural environment, how they fit in their world, what kind of vulnerabilities do they have? Is their neighborhood full of crime? Do they not have certain education or jobs or housing? Or all these are very important to hear as part of the context that the person is telling you is an important element of their situation. And you also want to know what they want to do about it. You want their perspective on what is the treatment or the help or whatever that they're looking for.
I think this goes in line with what you were saying earlier about criteria and diagnosis. You still want to learn about the subjective experience of the person you are working with. So I think the CFI does a good job of providing a space to learn about the subjective experience and how all the elements or the cultures that we spoke about earlier give meaning to these experiences.
Indeed. Mm-hmm. What you're looking for as a practitioner is a formulation of the person's situation that doesn't just take their symptoms into account. This is often what psychiatrists do, but too bad. I mean, it's a limited part. If they stayed there alone, it would be a problem. So we need to do more. And in that sense, there are many elements that form part of our formulation, and you want to know what they are in order. This helps you clarify them in order to understand the person better.
Yes, thank you. Next slide. Now we'll go to the uses of the CFI.
Yes, very briefly. Yes, thanks. There's 4 of them. Thank you. Yes. These are some ways of organizing the uses of the CFI. One is data gathering. That's the basic use. You want to know more about the person. So you ask a bunch of questions to find out their context. And in order, like I said, that's what I've been focusing on for evaluation and treatment. You want to know more elements of their picture. But you also, by speaking with them and asking questions, you're promoting communication, you're promoting patient engagement and empowerment. We were, in doing research on the CFI, we found one particular point that we asked people, what are these questions good for example, as part of a field trial that we did for DSM-5 around the world, 6 countries, in different parts of the world. They said that they're good for expressing caring, which actually surprised us. We didn't expect that. That a way of asking questions about what they think is a way to express that we care about them. It also empowers them in giving you ideas about what they want, what they need. The third element is in training. You want the practitioners to be thinking contextually. You don't just want to think about one person. You want to think about that person in context, their social world, their reality, their resources, like I said, their vulnerabilities. You want to understand where they live, what world they live in a sense. And you want to avoid this thing called diagnostic reification. That's just a fancy word for thinking that they are the diagnosis. You know, that in some way also not only them, but their symptoms are all they're going through. You know, you're focused exclusively on the symptoms they present as if they validated or didn't validate a label, and attach too much importance to meeting the criteria rather than the full experience that they have. So that's one possible benefit. And the final one is that this information is being used to inform place greater attention on person-centered services that are more socioculturally informed, you know, more safe from the sociocultural sense. You know, can you use them if you systematically interviewed people in your service? Would you be able to improve your service by finding out the things they're concerned about, the things they want, in order to provide? There were some articles written on that sense, provide better services.
Thank you. You mentioned that the CFI has been going through, let's say, evolution since the cultural formulation. It was a narrative, now it's a set of questions. Were there any changes from the DSM-5 to the TR?
No, not from the DSM-5 to the TR, because that focused only on the text of the manual. So the CFI is in some ways more like the criteria, you know, it's sort of the consensus questions went through a field trial. We would need a whole assessment. But there have been proposals for how to improve it for the next iteration, both the outline for cultural formulation, which is that narrative framework, which is also in DSM-5-TR, meaning TR has both, and 5 had both. We call it the OCF, the outline, and the CFI, the interview. They're both next to each other. But there have been proposals, for example, that we organize more, that we place more attention on the resource of vulnerabilities, the structural elements that people are coping with, as a way to organize the interview more, not only their interpretations of things, but their actual limitations or supports in terms of housing or employment, or that we pay great attention to that. So there's a movement now to pay great attention to social determinants of health, and there is a question whether the CFI, as currently written, captures enough of the social determinants. There's some papers that say they do, some critics that say, no, we need to do more, and perhaps we need to expand the CFI, or change some of it, or we need to add a second interview on social determinants that asks how housing instability has affected somebody's life or condition. The CFI asks what has affected your condition, and you can answer with housing instability, but it doesn't ask directly about how has the following social determinants affected your condition. So these questions about whether we should do that kind of thing in the next DSM.
Okay, thank you. Okay, so that's it for my section of asking you some questions regarding the CFI. So now we have some time for the audience to ask questions, make comments. So remember, if you want to raise your hand, we can open your mic so that you can share with us if you've used the CFI. If you want to use it and you have questions, please, you have the opportunity to ask Dr. Roberto Lewis-Fernández.
There's some comments in the chat.
Mm-hmm.
About working in a rural community and we don't have Latino services and symptoms are often not treated. Well, the idea of the CFI is to ask what has helped and what hasn't helped, for example, of the person about past treatment or current treatment in order to help elicit attention to the things that have not been addressed. But again, we face such a difficulty in the absence of services or attention to all kinds of symptoms in people's life. There often isn't much of a trauma-focused approach, and trauma can be very prevalent in our communities. Oh yeah, Ken Kendler. Kenneth Kendler, Kendler. And in 2017, if you look up the word illustrative and the word DSM, you would come up with his article. I think it was in Psychological Medicine, of which he was the editor, but I don't remember exactly. How do you deal with Latino stigma on treatment, especially men? Well, that goes a little beyond the topic of the conversation, but it's definitely something I've had to deal with. It's important if you get a chance to interview people about it, and you can use the CFI for this sort of thing. You can ask other people who come in, what are the barriers, if you will, that prevent. For example, one of the questions of the CFI is what obstacles have they encountered, if anything has prevented their ability to get the care they need. And there, after you open the question, you could ask specifically about any objections from family members, for example. And but that means they're already in treatment. They've already shown up. How do you overcome stigma barriers to actually show up at all? And there you could try to institute general, training campaigns, teaching campaigns, all sorts of things. But you can also, if you get the men in the room, it's important to interview them, ask them what it is they object to. Maybe it's a label that they object to, or they feel blamed for, or they think it's just a person's complaining too much, they're weak or something. These are very important things to understand and try to negotiate with the person. I mean, it's I'll tell you that as a man, I'll just say the men are just as oppressed, if you will, not just as, but they're oppressed as much by the idea of patriarchy as women. I mean, it's a bad thing for all of us. So if you have to live a life in which you can show no weakness, for example, because that's just a horrible way to live. You much better to be able to express when you're concerned, when you need support. And often people have the label of local, that they have in mind, and we could just try to normalize our services as being services for everybody to help with life problems, not just for people who suffer from psychosis.
Mm-hmm. Mm-hmm. I think the person-centered approach it really helps with that and really understanding where some of these ideas may come from. There's a question about the CFI and possible use by promotoras.
Yes, luckily we wrote the CFI so that it can be used by anybody with any patient or person in any setting. So we've tried it in, we have a training program that my center for, it's called the Center of Excellence for Cultural Competence in the New York State Psychiatric Institute. So if you look up cultural competence, New York State, that sort of thing, you should get our website. And it includes a section there's a training, 55-minute or something, module that you can access. And it is intended for use by anybody. So it has an example, it has videos. And one of them is an unemployment agency, an employment counselor. Another person is in an ER. And the idea, the provider and the people coming in for particular needs. So it's possible for, we think, for any provider to, it's written in a very general way. What do you think what brings you here? That kind of thing is how you start. And then you shape the questions according to the problem that is bothering the person. So yes, it's easy. It should be, we hope, that it's easy to use by any level of training or practice. Is there a DSM-5 for Latinos? No. And there isn't. There's a DSM in Spanish, but that's not the same thing. The idea is that we should, there would need to be a DSM for everybody, meaning for any single different person. And that in some ways, what the DSM does is it lays out certain Western ideas of disorder and then asks you to validate whether those Western ideas, the ones that you get billed for and so on, are valid for the person. So each person is different in that sense, Latino, not Latino, there are differences among Latinos. So you would want to see if the symptoms or the problems that the person is having fulfill any of the criteria in the manual. And if they don't, explain how. For example, the person doesn't have the 9 symptoms, I keep using major depression as an example, doesn't have the 9 symptoms of major depression, but they have these other symptoms or problems that are very typical of anxiety, depression, somatic experience, any number of things, and therefore they need treatment, But we want to do it on a person-by-person basis of adaptation, not a large population of Latinos or Chinese from the western side of China or the eastern side. There are a lot of differences between people. Trust, develop trust, share their world, very personal, empowerment. Yes, I agree with everything you're saying there. Right, that's a very good question. Next, very complicated. What do you recommend when people's cultural ideas conflict with treatment recommendations? I have a pet peeve with the word beliefs. It's not you. I mean, I'm not trying to criticize you. It's a word I don't like because it always implies to me falsehood. There's a sense that we don't call what we professionals think as beliefs. We know that things are a certain way. I prefer to call it knowledge. So the people have various forms of knowledge. There are various forms of knowledge in the world. And these are regional, cultural, whatever specific knowledges that people bring of their life, of their, belief. I tend to restrict to religious belief. Mm-hmm. Like you believe in things that there's not possible, if you will, from the scientific perspective, to have knowledge on. But when there is, you say, I believe the sun will rise tomorrow, it's a statement that implies a certain lack of certainty. Of course, it's never uncertain what's going to happen tomorrow, but, anyway, you know what I'm saying. I prefer word knowledge. But yes, cultural belief and cultural ideas say, and clinical recommendations, it's important to negotiate them. That's a word I use all the time. And the CFI is helpful to try to flesh out what they think. They may think many things at once that aren't all integrated. And by asking those questions, you ask them questions about how certain they are about some things or another, and how can you find an intersection between what the doctor is recommending and what they want, for example, or how they interpret. For example, people often use metaphorical language in rather concrete ways. Like, for example, ideas about witchcraft or brujeria or something can be both very subtle, deep, and too concrete at the same time sometimes. So they may sometimes mean that there's social problems that are being expressed in the community that are being expressed in the language of brujeria. But that doesn't mean they're psychotic or they believe in very unlikely things. It just means that they're sensing often interactions between people that they need to be, that they express and understand in a supernatural language. So there's ways of translating aspects of that supernatural language into clinical possibilities. Is there a way you can protect yourself from the experiences in your community that are negative for you? It doesn't mean that you have to endorse necessarily, if you don't believe in it, certain brujeria defensive practices, but you can address how community or intersubjective experiences are affecting the person. So also medications, there are ways to, I use medications as a psychiatrist. There's a way of framing the medication in a way that can be building up the body or helping the person sleep or coping with certain elements in the brain that have been a bit disrupted by so many years of experience, but it doesn't make the problem go away. The difficulty is in thinking that you just have one solution to a problem, that's the one you're using, and no other solution helps. That's a very unhelpful attitude. It's how to combine from many practices and sources things that might be helpful with what the person is doing and what you're doing, and then also to challenge the ones that may not be helpful. Like if they think violent behavior is helpful, well, it usually isn't, except in the cases of extreme need, protection and personal defense,
Mm-hmm. Thank you. There's another one on possible use with adolescents and young adults.
Yes, adolescents and young adults we have used successfully. It's when you use with younger than school-age children and even pre-adolescents or very people who have difficulty with brain function, intellectual limitations of some kind, and can't have a kind of perspective on their life, the very, very day, moment to moment, that can be a little bit more challenging. But young people, very psychotic people has been a problem. But somebody with chronic psychosis who has reflective capacity, that has been shown to be successful. So there's work being done on how to adapt it with play therapy and other things. And there's just a couple articles on this. There's a psychologist by the name of Martin Laroche, Laroche, who has been working on preschool children. Yes, Isabel, Public Policy Academy.
Chicago.
What's that?
She was in Chicago with us.
Yes. How are you? Developing with team involved in creating. Oh, I see. Psychiatrist. Okay. It was mostly psychiatrists. There were some psychologists. Originally, there were a lot of anthropologists who developed the outline for cultural formulation. The CFI itself, the DSM-4 involved more anthropologists than the DSM-5. So it was mostly people who were double trained, who had a social science background, who were clinicians with a social science background. Most, as in the DSM, most were psychiatrists. It's actually internationally there've been a lot of psychiatrists adapting the CFI. So we assembled people from around the world who worked on it, from the Netherlands, Sweden, different. The Nordic countries are very interested in it for some reason. There's several folks, but there were some psychologists, and I don't know if any social workers, actually. That is the general way in which the DSM has functioned. Sorry to say. How did you assess reliability, validity of each area proposed in the answer? It's interesting. We focus mostly on the interpretability of the questions. So and the content, the themes that were being assessed. So in developing the field trial, we didn't compare it to another interview, which would imply the validity question, but we more checked how reliable each of the items were in terms of the people's reactions to them. Not so much if they were. Let me tell you what we did. We actually did a debriefing interview with everybody who participated in the field trial, and we asked them about the questions. It was patients, providers, and family members who participated, and we asked them which questions need help, and we then changed the wording of the questions based on their answers, and we had an associated measure we created that asked questions about the usefulness of the questions for particular domains, how acceptable they were, how feasible they were, and we looked at the reliability of those answers, the internal consistency, basically we looked at the content and the form of the questions, but we didn't do a reliability assessment of the questions themselves. And we didn't do a comparison across populations. We tried to make it as intelligible in India, where we had a couple sites, as we did in Netherlands. Tell us that we need to go deeper into cultural formulation during a session. If you're not understanding the person's answer, or the person seems to have a lot more to say that isn't covered, that is the beginning to say something, but they don't continue, and you want to probe further, you can either probe with the probes that we include in the CFI itself. Some questions have probes, or there's a separate measure. For example, if you discover that cultural identity is complicated, they have all sorts of facets of their identity that are making a difference to the current situation, and you want to know more about, say, their migration history, or their gender orientation, gender identity, or their sexual orientation, then there are particular aspects of the questions that are suggested for you to probe in a supplementary module. But it's when you discover that there's more to it than you fully understand, or that it's worthwhile to go deeper. The thing about the CFI is you can ask more questions. I mean, this is just a baseline, if you will. You can do it simply. We assessed that it took 22 minutes to do the CFI that we did in the field trial after one training. If you did it once, you could do it in a short period of time, but you can do it longer. Thank you so much. Thank you so much. Okay. We're running out of time.
We're running out of time. Thank you so much. As you can see by the comments, our audience really enjoyed the presentation. They're letting us know that this was a learning experience for everyone, that it has been a pleasure. Thank you so much. And on behalf of the center, again, thank you not only for this, but for being part of our family for many years now. We appreciate it. And to our audience, we hope that we strongly encourage that you complete our evaluation. You have the QR code, you have the link available. You can use either one. We have it available in English and in Spanish, as I mentioned before. Completing the evaluation allows us to continue to do the work that we do, and we hope to continue for a long time. So appreciate everyone taking the time to complete it.
I want to say hello to Mari Carmen Benazar, who is in the audience. I haven't seen her in a long time. She was my research assistant, maybe, I don't know how many years ago. She's now a psychologist in a training program in Boston.
Correct. She said correct. There you go.
Thank you for including me.
Oh, thank you. We'll leave the evaluation link for a couple minutes so everyone can get a chance to complete it. No, we do not have CEUs available right now, but we're working on it so that we can be able to offer them soon. So stay tuned.
Mari Carmen said it was 1992. Can you imagine?
That was yesterday.
Yesterday, yeah. For some of us, it was.
So we're sharing a poll on some of the work that we're doing. Thank you for completing that as well.
Somebody asked, I don't have a book on my philosophy of mental disorders, but there is a book on the DSM-5, CFI, that several of us edited. It's called the DSM-5 Handbook on the Cultural Formulation Interview, if you want to look at.
Thank you so much, everyone. And thank you so much, Dr. Luis, for your time today.
Sure. Happy to do it.
Yeah. We're going to finish today's interview or webinar. So everybody, thank you again for being here today.